Hey, this is Ayala with Atlanta Against Cancer at Atlanta Against Cancer Week at Ponce City Market. I'm here today with Stephanie Braatz, Chief Clinical Officer of Piedmont Cancer Institute. Atlanta Against Cancer, we focus on creativity, culture, and community with a focus on cancer. So, Stephanie, thank you so much
thanks for having
coming. And I do my introduction very professionally, but the rest of this is, and it's professionally is seldom. But first of all, thank you for coming. I think it's amazing. I know a bit more about what you do, but would you kind of who you are, what it means to be a chief clinical officer, and then say a little bit about you have worked in this field for so long, so just a little detail to that.
Yeah, sure, I'd love to. Thanks for having me. Not often I get to brag on what I do and who I get to work with, so happy to do that. I'm an Atlanta native, born and raised here in Atlanta. I don't meet too many of those, and kind of grew up always thinking I'd be a nurse. I'm not real sure why I was drawn to that, but I can't really articulate that, but always kind of knew I wanted to do that. And first job, when I graduated, there wasn't a nursing shortage. Go figure, because it's huge now. But first job happened to be in oncology. I was offered a spot working night shift in a hospital that said they had an oncology unit. And it was a little bit of oncology and a lot of other things. But that's where I first met oncology and the patients and really discovered how special they were. So maybe it called me, and maybe I just got lucky. But I started working in oncology, and then it just kind of grew from there. I did inpatient oncology, and then really found a special spot in outpatient oncology, where the bulk of diagnosing and treatment plans and actually treatment happens these days for most oncology. So I'm at Piedmont Cancer Institute now. I started there as what I call a baby nurse. I was in my 20s. I've been there 21 years now. I just had my 21st anniversary there. And
That's a woo woo moment. Yeah. That's a woo woo. Yeah. Sorry about that. We should have woo wooed it earlier.
You don't find people that first you don't find a lot of Atlanta natives, and second you don't find a lot of people that have been working at one place for 20 plus years. So
certainly
it is kind of unique, and it is something I'm proud of. But I started at Piedmont Cancer Institute as a nurse, working in the infusion room and in the triage area, doing a little bit of everything, and really found a groove there. That's where I've learned the most about oncology. I will say that cancer treatment, oncology in general, was a lot simpler then, but not necessarily for good reasons. We didn't have nearly as many treatment options then.
Okay.
We didn't know as much about oncology then. We didn't know about all these genomic alterations that maybe you could switch on or off and really target something. We just sort of had the the hand grenade effect. You throw the hand grenade, it takes out everything in its path, right? That's kind of what cancer treatment was 20 plus years ago. Over the years, it's gotten a lot more complicated, which will drive you crazy in some aspects, but in other aspects, our outcomes are so much better, our symptom management's so much better, we're diagnosing people so much earlier, so they live longer in general. So, like I said, I really sunk my teeth into oncology when I started there. And then I've done a little bit of everything there. I worked as a nurse. Then I went back to school and became a nurse practitioner.
Okay.
That's a master's degree.
That's it's the weird part about having you here is this might be the only time we've ever been allowed to say might be medical advice. But they, mostly we pretty much always stick to don't believe anything we say because it's mostly us complaining and that's it.
Yeah, but you might be able to believe a little bit of what I say.
That's fair. It's it's actually a really nice cosign for us at least to have one of these. Thank you.
So I worked as a nurse practitioner. I was lucky enough that PCI kept me on as a nurse and let me work part-time while I was in school.
Okay.
So I worked part-time, by day nurse, by night grad student, and then they hired me into a new position, and I worked as a nurse practitioner for another 7-ish years. So that gets us to about 8 or so years ago, when they kind of probably asked me for about the 4th time if I would assume a administrative role. And I always say, sort of kicking and screaming, I was drug into administration. It's not where I really saw myself being, when I was a little girl dreaming of being a nurse.
Is that like, what's the diff? I know there's a difference, but what is the difference?
So as the chief clinical officer, I have a team of about 150 people, and I'm not in direct patient contact anymore. That's the worst part of it, I think, because the people is what I really enjoy. So instead of managing a chemotherapy infusion, now I'm managing the processes behind that chemotherapy infusion, or sometimes the finances behind. Not that I'm not that I'm managing the books, but looking at options of.
That's the second thing we don't give advice on.
No, me neither.
First for us is medical, because we could save a life by not believing us, and then second is financial advice.
Right.
So.
But I'm trying to make sure that we have all the safety things we need in place, both for the patient and for the staff. Making sure that our processes are very consistent across different locations and different people. And making sure that we're staying on the cutting edge, too. Of course, there's a ton of people that help us do that. But
and that's what's really interesting. I think one thing about Piedmont Cancer Institute that drove me there, other than my cancer, but it's a great way to get into the cancer industry.
I'd say so.
Yeah, I guess so. But the thing is that you guys have all these different locations, and I found it to be really interesting that it was private, that's the word, which was confusing in itself. And it's Piedmont, but it's not Piedmont, but it is Piedmont. But when you call, there's not an answering machine and things all those little details. And kind of what I'm picking up on is that it sounds like such a logical hire from within system, like by hiring the nurse who's went from the nurse to the nurse practitioner. I don't know is there something above nurse practitioner?
Just different responsibilities, probably. I mean, you can certainly get a doctorate in nursing. So there's just different sort of where you would find your niche, I suppose. But, I love baseball. In baseball, you have a farm system, right? You have your minor league, as you grow, maybe you make the major leagues. And so sometimes I like to think of it as that. You come in as sort of that novice, and then you build and you build, and you identify things in different people and try to nurture that and foster that. And I think if you're lucky, you get some long-term employees and long-term people that are like-minded and think like you do, and the other members of your organization, and that's how you get a really strong team.
So I mean, part of being Bebop, being Atlanta Against Cancer, and what is that? And it's so interesting. We're so new. We're such a new concept, and what's really cool is that over this year especially, we've started to grow a community, and that's so strange to me. It's just, I don't know the word for it. It makes me feel weird, okay? But the point I'm getting at is that there's a fine line when you're a patient between disparaging a hospital and telling them something could be better. There is that line, right? Because what is interesting, and I think, because I have a bunch of questions, and some of them are kind of nerdy questions that may not be interesting to everybody, but I'm okay, I want to know about
Now's
this.
your chance.
We're talking about the money here. Okay, where's but as a chief clinical officer, you've had the experience of being an oncology nurse, a nurse practitioner, so you've heard the beeping that I couldn't imagine. First of all, the beeping for us as patients, that beeping's real, and you guys all know what the beeping is. I don't know why I'm even asking that. But as a nurse, you must sleep with the beeping in your mind, right?
Yes.
And I'm using it as an example of while that one is probably an important thing to have the beeps keep going, but as a chief clinical officer, now you kind of. I don't know, you get to make those changes in some ways. And are there any things specifically that you've done that are like use case scenarios for that kind of thing, where you've learned that patient, and we do cuss a lot, I was going to cuss there, but you can or don't have to, it's up to you. But we like patients hate this.
Yeah.
This is the thing they complain of.
Yeah, and actually you touched on something I think a few minutes ago when you said when you call our office, you get a person. Mm-hmm. So that wasn't always the case. Now, 21 years ago when I first started, we had 2 locations and 50 employees. That was the case.
Okay.
You called and, the girl at the desk said Piedmont Cancer Institute.
Right.
But as we grew, things evolved and we got a phone tree, right? So when you called, you got a person, but it said press 1, 2, or 3. So, growth comes with hiccups and growing pains, and so now we actually have, but to the point that patients would say, I'd like to speak to my doctor's nurse is the button they would press.
Right.
And when they did that, they hit a voicemail. And when you hit a voicemail,
I hate that.
Yeah, you don't know if did they get my voicemail?
It's funny because I want to complain at you so bad. I know. And, I just want to relive trauma and complain and be like, I finally met the, you're going through the management and you're like, let me talk to your manager.
And I'll tell you that the nurses
here.
hated the voicemail too. The nurses also hated the voicemail.
I got to imagine they hated the voicemail.
Because they had this phone sitting on their desk, and when there was voicemail, there was a red light that would blink. Mm-hmm. Well, they hated the red light. I had nurses putting Post-it notes over the red light so they wouldn't see the red light. So 2020, actually, we reconfigured because we knew the patients hated the voicemail. We knew the nurses hated the voicemail. And when you got the voicemail, I might have 10 people in my voicemail. Well, I didn't know if the first message was the most important message or the 10th message was the most important message. But I had to listen to all of them to figure that out.
My biggest complaint on the voicemail thing is how it starts off with, if this is an emergency, call 911. Because I'm like, I know.
Yes.
I know. If this was an emergency.
Well, some of that, we might need to talk to the lawyers.
But that's the thing is I think that you've had such a perspective on each phase, and that's where from finances to a hospital's impact on a patient it kind of goes without saying, right? But being Bebop, being Atlanta Against Cancer, we talk about so much of the everything else, right? That's really, now that I say this out loud, that is what we talk about. Everything else is I barely know my own medicines, which is a whole other thing, but when we talk about these interactions with patients, a good patient, would you say that a good patient is a quiet patient? Is a good patient I know I'm kind of, in some ways, that's sort of a setup for failure question, because then you're like, well, a good patient is when. But what I mean by that is that it's got to be, it's one of those jobs that doesn't stop. In a good day, really, rather than good patient, a good day can be a day where just nothing went completely off the walls, right?
Yeah, but sometimes a good day is watching your team come together to adequately or to spectacularly manage a patient. A patient has, unfortunately, patients have infusion reactions during some of these infusions they're high risk, often high reward too, and they have an infusion reaction, and you watch your team come together and really quickly and just knock it out of the park and really get that patient back where they need to be quickly, all the while reassuring the patient, reassuring whoever's with them, documenting up to, such great documenting. I mean, that doesn't mean much to a lot of other people, but within my job, that's really a good day. Now, for the patient that had the infusion reaction, that person might not consider that such a great day, but the fact that they were surrounded by such good support staff, really illustrates the team that it takes to get a lot of this stuff done.
And I think it's so interesting because, and it's funny, I want to Piedmont Cancer Institute and Piedmont Cancer Institute is also a sponsor of everything I do.
Full disclosure.
Yeah, I mean, like, both saved my life and continues now to sponsor it. They haven't given up on me through that's a past services. But the idea that when I was there, I had this experience where, I chose Piedmont Cancer Institute because of my scheduler, Kelly. You know Kelly, of course. So, like, and in my phone, I was saying earlier that in my phone, Piedmont Cancer Institute's name is Kelly. And, like, I forget sometimes when I get, like, robocalls or whatever, different things calls in, and it'll be like, who's Kelly? And then I remember, I'm like, this whole, story goes through my mind. And what's so interesting, and I'm not going to say the other hospitals that I've gone to because that would be bad, but they have so many people and they're so busy and they're so you do feel not just like you feel like a number because there's the waiting room. You're waiting, like you're waiting in the waiting room.
Right.
It's not a stop and go kind of thing. And as a chief clinical officer and the way you've kind of described the position, like how much of that do you guys take into what you do at Piedmont Cancer Institute? Like those kinds of like little instances.
Yeah, experiences, right?
Yeah.
You're gonna, and to your point, it is a waiting room. You can call it what you want. You can call it a reception room. You can call it a waiting room. You can brand it however you want, but you're going to wait at least a little bit in there, right? But those are things we look at. How long are people waiting in the waiting room before the next step happens?
Sure.
And we're always tracking those things and trying to minimize that wherever possible. And make that experience as pleasant as it can be for you. Do you have a comfortable place to sit? Do you have a comfortable, is there something nice to look at? Are our people in that area, are they friendly?
Sure.
Are they engaging with the patients?
And I think that's the whole thing is like when I think of being in cancer, I think of the chemo chair for me.
Right.
That was my experience, like surgery was quick. I was awake. Then I was awake again somewhere else in another room with different clothes on.
Something happened in between there.
But the thing about it is that the chemo chair, that's my my memory set. But for other people, and we talk about it all the time. That like the human. Sorry, I got a little distracted. The cancer experience doesn't negate a human experience.
Right.
So for me, where the chemo chair may be the place where I got it, the waiting room could be for another person, or the sitting in the post-surgery or pre-surgery. It's interesting to me because not often do we talk to a person in your position who's kind of seeing that 30,000-foot view and saying, like, there's a connection there.
Right.
Where do you feel as though in the hospital space you sort of, I don't know how, I feel like it's a bad question to ask, but do you feel like you have to hit minimums? As in the sense of like, your goal for me, like in most businesses, they can have, we can have the best restaurant, but the wait staff isn't great or the ambiance wasn't amazing.
Right.
But do you feel like with the hospitals, industry, you need to hit your minimums in some ways, make sure people have what they need over did they enjoy their stay, right? Because that fight, but that's what's going on in the patient's mind so often is the fight between the two.
I would say as an organization, our goal is always to exceed your expectations on everything, whether it's a low wait time or an engaging staff member or a billing specialist that just knows her stuff. I mean, we're all pieces of the puzzle. So, when you look at a puzzle, let's say you do a 100-piece puzzle and you get down to the end and you're missing one piece. Well, you look down and the whole thing's kind of ruined, right? Because there's one piece in the middle that's missing and it's just not complete. And that's really how I kind of think of our team. Like everybody has to achieve at a high level to provide what we need to provide to the community, the patient, to everyone.
I mean, minimums was a kind of a harsh word to say
Yeah.
it. The idea though is like, it's phenomenal to me when I go to a hospital and I think of the nurse who woke up just to come to work, but her work was sitting in me complaining, and
Right.
putting
Right.
me.
Right.
If I'm having a bad day,
Right.
I'm not always this person, but it takes so much, and it really is interesting to look at it in the sense of that puzzle because, if I'm missing one piece, I'm pissed.
Yeah,
I'm incomplete.
I am too.
I didn't finish, and so
I worked
I
so
see
hard.
that
We
kind
all
of
worked
as-
so hard, and we're missing a piece, and not just we're missing a piece, but the end result is that the person on the other end got that missing piece.
You know what's strange is that
Yeah.
we don't hospital advocates are not a thing I know about. Like you, in some ways, that you're the first person conversation, like in a business setting, if we call this a business setting, that is a hospital advocate in some ways, because otherwise it normally feels salesy. We lose that sense of the hospital industry is trying to buy me as a patient.
Yeah, I mean, it is a competitive market, right? I mean,
Right.
You don't want to think of healthcare that way because
Right.
because we're supposed to be caring for people. You don't want to think about it as a business model necessarily, but you do have to pay the bills.
Of course.
And by paying those bills, we're able to care for more people.
Right.
Piedmont Cancer Institute is privately owned. We're not backed by a hospital system. We partner with hospital systems. We're very good partners with Piedmont Healthcare, but we're privately owned, and I think that brings with it a great sense of community.
Yeah.
I think with our multiple locations, we're able to we like to say we bring cancer care to the community. So we're not just, you don't have to drive in town to.
I'm telling you,
can drive
when
in
I
town,
learned my experience at Piedmont, I'm not a good person to do this interview in some ways because I've had such a great experience, so I'm kind of biased.
Oh, we're happy for
but
that.
Mostly because of the access,
Yeah.
and the privilege that was for me to have. I'm a big believer that really what is privilege, and it's being able to have a fallback and being able to have choices. I had the privilege of choices, and I was lucky enough to come across at the time, at the day, whatever it was, and to think that a person like yourself is there who's I'm trying to create these perfect storms for people in some way, where they're really struggling. This is for most people. I mean, this is the worst. And
often the first visit to our office is sometimes the worst day of people's lives, and because they're getting news that they never thought they'd hear, and we're very sensitive to that. That is a pivotal moment in those people's lives. And so we're there to provide education, to help you make choices. We don't make choices for you. We're there to provide you with the education because we have the experts that can guide you through it. But we are very sensitive to that, and we should be.
Yeah, 100%. I mean, and I know we have to kind of round out, and I said, I actually find the more I've learned about the position you hold at Piedmont Cancer Institute and the position you and the vantage point you have of looking around at other patient friends and the person in your position and having worked as a nurse practitioner, you see so much, and it's such an emotional topic. Cancer, there's so much emotion to it. So this sorry about that, how you make those decisions, it baffles me. Because you have to weigh so many options for what has to happen. And what would you say, because in rounding it, what would you say are some of the biggest needs? And I don't want you to I don't mean to disparage the great name of Piedmont Cancer Institute, but I mean in the medical field, as far as this professional job, we need to for us to 10x, to go to the next
Yeah.
level, to be the best. Because I could tell you all about murals and fun socks and
Right.
getting communities together and social content and
Right.
stuff. I'm a
Yeah.
great stuff person. But from your vantage point, like, what do you think do you have a thought on, like, what is the way that, medicine goes to this next level that it,
Right. Right. I think there's a lot of things. One, we need more nurses. So I'm going to look into the camera and say, go to nursing school. We definitely need more nurses. We need more people drawn into the healthcare field because population's getting older. We're diagnosing things earlier. People are living longer. So attracting people into the healthcare space is one thing. I think another thing is I think there are areas of healthcare that definitely need some simplifying. We've gotten so smart about all these little biologic levers and things we can turn on and turn off, and therapy gets more and more sophisticated. But things like insurance companies, payers, Medicare, their policies have gotten a lot more complicated, making it much more difficult to get people treated in a very efficient way. Many times the waits that patients are experiencing are not because we're not ready to do it, but because we can't get authorization to do it, or we've had to jump through a lot of hoops in our own wait periods that are mandated by someone else to get that to happen. Listen, the general public does not understand that, and I'm not sure how much I want them to understand, as much as I just want some reform in that payer space that's really kind of complicating things a little more than they should.
The back and forth of what you do,
And that's kind of what, when I talked about oncology being a lot easier or simpler 20 years ago, that feeds into a lot of that too. 20 years ago, doctor prescribed a treatment and you did the treatment. You didn't jump through a lot of hoops. That's right. And some of that is very good, and some of that has, I think, created some bad actors that maybe have gotten a little out of control.
Dare we say? No, I really appreciate it. We have to round out, but thank you for this. It's an insightful look. It's a different thing. We don't get to do this a lot with Bebop.
Thank you.
We honestly we get to yell and scream and kick our feet a lot, but we don't get to take it from that perspective. So I think you've done so much for us as a company as well, and I think that we could say thank you and to continue doing the work you do, because I think I would not have known we need more nurses. So that's a really interesting thing. We got to attack that. We got to go for it. I don't know why, but I'm putting it up there.
Well, it was my pleasure to be here. Thank you so much.
Thank you so much.